Hello, welcome. Is there anybody out there at the moment? We're just waiting for everybody to join us for these last couple of minutes before we kick off at 12 UK time. And all of our panelists are here. We've run through the slides. Fingers crossed everybody's broadband holds up. And we'll be good to go on the hour. Till then, I'm just going to put myself on mute. Okay, so that takes us over to noon and the start of our very first radiation protection and the impact on the clinical environment. We've got our panelists all on here, and I can see from our number of participants, we've got 60 people joined us already. Many more of that have already registered, so we should crack on. We have so much to get through in an hour. I've just been through the presentation material, and the information that we've got coming up over the next hour is world class. And I hope everybody gets something from it. First of all, I'd just like to say thank you to all the speakers for putting the time in, putting these presentations together and liaising in these times over the Zoom and Teams and all sorts of other remote platforms. To you, obviously, the audience, I hope you've got yourself a sandwich and a drink for the next hour, and hopefully you'll get some good information and value out of the time over the next hour. My team at APC have pulled this together, and also, really importantly, the sponsors who have supporting us here from WIT and from Lighttech. So our objective here is to help you reduce your exposure to radiation. And you're going to be really busy, aren't you, at the moment with all the patients and clearing backlogs, and it's always an issue. So what we wanted to do was help you with reducing your radiation protection. Obviously, we've got the things that you have around the fingertips, but a really important part of reducing radiation is education. And from one report I saw, you could reduce the radiation in your clinical environment by up to 20% just by having a good educational program. And we do that at APC Cardiovascular in normal times. We do lunch and learns, and we've put this together because we're not able to do that at the moment. So with the philosophy that the only safe level of radiation is 0, it's a bit of a mission, I know, but it's something that keeps us focused. I'd like to start our next hour and introduce our first speaker, which is Dr. Tara Mastracci. And Tara is the Clinical Director of Vascular Surgery at the Royal Free Hospital. And she completed her training and studies in Ohio and moved to the UK for her interests in complex aortic repair. And she's also worked very closely with the radiation physics department at the Royal Free to improve radiation safety in the field of vascular surgery. So without further ado, I think, are we on to that's the introduction slide overall, and I'll come back to each of the speakers before their section. So if we can move on to Tara's slides, David, to start us off, and over to you.
Well, thank you very much for the kind introduction and for the opportunity to take part in such a great educational session. I am but a mere opening act for some really awesome radiation researchers coming up in the next couple of talks. So my goal will be to give you the fundamentals, and hopefully Bijan and Eric and other people can kind of expand on things. If I could have the next slide, please. I'm going to show you the excerpts of a video that my radiation team and I actually built, and these are just some of the other authors of the video. And I would highly recommend that you download it from YouTube and use it for your own teaching. It's really only about 5 to 7 minutes long, and it has all of the fundamentals that you need, and it's kind of in a fun little animation. So it's good to kind of brush up on the fundamentals. Next slide, please. I think I probably don't need to spend too much time introducing why this is a problem that we need to pay more attention to. It's clear that in almost any population where it is measured, the burden of radiation in our day-to-day lives has increased. And a lot of that is coming from an increased interest in ionizing radiation-based therapy and diagnostics across the board. Next slide, please. One of the things, as Stephen alluded to, that's really important if you are going to be a clinician who provides ionizing radiation for either therapeutic or diagnostics is really to be aware that dose is important and that it's within your power to decrease the dose. There's been a number of different studies that have shown that if you increase awareness in your team about the importance of reducing radiation dose and that everybody really plays a role, that alone will make a significant difference in the dose that you use. Next slide, please. I think a lot of people are really nervous about radiation, largely because it does involve physics, and sometimes it can be a bit confusing. I am a biochemistry major before I went into medicine, and so I am by no means a physicist. But I can tell you that there are some rudiments of radiation that are reasonably easy to understand and are probably important in kind of sorting out what the fundamentals are for your own practice. Next slide, please. I think it's important, first of all, to know that ionizing radiation travels through the body, and one of three things can happen to it. It's either transmitted, scattered, or absorbed. And if it's absorbed, that's when the radiation has an opportunity to do damage in our patients. If it's scattered, that's when it has the opportunity to do some damage for us. Next slide, please. The energy that is deposited in either patients' tissues or our own can have two different effects. One effect is DNA damage, and that's what we usually call the stochastic effect. It's not dose dependent, but the likelihood of it happening increases as you're exposed to more doses. The second effect is the deterministic effect, and that is really when the radiation causes cell damage or apoptosis, and that can lead to skin burns or cataracts. And this is dose dependent, so really the reason why we offer threshold levels or threshold markers in order to determine how much dose a patient or ourselves have had. Next slide, please. So radiation scatters when it traverses the tissue. And as I said, this is really the leading cause of occupational harm, which is why standing as far away from the source as possible is important, but also figuring out ways to shield the patient so that the scatter doesn't come onto you. Next slide. This is probably one of the most mythical and difficult things that people talk about, and that is how we measure the quantity or how we quantify radiation. So you can look at it in two generally large programs. One is absorbed dose, which is the amount of radiation per unit mass. That's measured in gray, and that's what we look at for the threshold effects, really. It determines our deterministic doses. The second is the effective dose, which measures the stochastic effect, and it's a calculated dose, so it's slightly less easy to understand, but it's weighted according to the different tissues that is exposed to. So measuring X-ray doses is actually impossible to do directly, and therefore X-ray systems report a bunch of different types of measurements. Fluoro time is the one that people used to report the most frequently, but it's really inaccurate because it doesn't give you an idea about the acquisition level of radiation. Cumulative air kerma is the dose level at a reference point just approximating the skin dose. And this gives you the best risk of skin injury. And the most important, in my opinion, the most important dose that, measurement that we report is really the dose area product. And this gives us the best understanding of our risk of long-term. Next slide, please. So the safety standards when we're looking at radiation are really universal. And there's 3 of them. If you can move to the next slide, please. Justification, optimization, and limitation are the 3 main tenets of safety around radiation. Justification means that you as a physician agree that the benefit of exposing a patient to radiation outweighs the risk. Optimization is this concept of doing something as low as reasonably acceptable or as low as reasonably achievable. And that's where you get to tweak all of your techniques so that you can try and get a low radiation dose for what you're trying to do. And then obviously limitation is where we set limits. So if we get to a point in a procedure where a patient has been exposed too much, we know that it's time to stop. Next slide, please. There are a lot of different ways to limit exposure, and I suspect the next couple of speakers are probably going to spend most of their time talking about that and the damage that it can be done if you don't. I found it really useful when I moved to the UK to sit down with the Siemens guys, because we have a Siemens system, and really talk about the doses that they're giving and the different settings so that I understood what the protocols were in my hybrid operating system. The X-ray exposure should be controlled by the operator. You should be pressing the pedal if you're doing the procedure. And I would go so far as to say that you should also be moving the gantry and moving the table so that you can make sure that you're as accurate as possible. Collimation and filtration are really important because they reduce scatter, and trying to be as aggressive with this as possible is important. The protocol that we do at the Royal Free is that the radiographers in the room are responsible for that. And they do a really great job just staying on top of the collimation and filtration. Limiting magnification is controversial, but it's important because it does decrease the dose if you have a wider image. And therefore, having larger screens have been shown to statistically improve your ability to see without needing magnification. There is some belief, though, that magnification actually decreases the scatter. So you may get a bit of controversy through that. And finally, one final tip is to use saved fluoro runs instead of DSA, because DSA really is responsible for the bulk of the radiation dose that you're giving in any procedure. Next slide, please. Finally, and most importantly, so it really warrants its own illustration, is keeping the patient as far away from the X-ray tube as possible. So raising the table so that you can do most of your procedures, and then keeping the X-ray tube as far away from you as possible. So if you have to do an obliquity, moving to the other side of the tube so that you're not getting the scatter. And that's one thing that will definitely decrease the deterministic or the skin doses that a patient will have. Next slide, please. You're going to hear Bijan talk a little bit about the personal protective equipment. I personally use a lead garment that has sleeves as well to protect the armholes and breast tissue. A thyroid shield that fits well is really important. Lead glasses that have lead on the sides, not just on the front, so that your eyes are protected from all angles. And then finally, ceiling mounted and table mounted shielding, and in addition, a shoulder on top of the table if possible. And then of course, it's useful to try and employ any other possible disposable shields as possible, like the Radtke that helps prevent some scatter coming up from the field itself. Next slide, please. This is a much less sexy, once we get to it, a much less sexy but real-time picture of what my theater looks like at the Royal Free. You can see we have a Siemens Zigo that's reasonably old, so a lot of very small screens were implanted at the beginning. We've augmented it with some auxiliary large screens so that we don't have to use magnification as much. You'll see that the ceiling-mounted shield is actually only on one side of the table, so we use Radtke to supplement the other side. But we have really good table-mounted shielding and a shoulder, as well as being in lead gowns and complete with long bone protection, so lead boots as well. One of the things that we found has been most useful in decreasing our overall team radiation dose has actually been the introduction of fusion imaging. Next slide, please. And what this is, for those of you who don't know, is the ability to fuse the preoperative CT scan on top of real-time fluoro images. You can do this two ways. One, with a hardware-based approach, where the table position is noted by the imaging technique, or the second is by an imaging-based approach, such as what you're seeing here, where there is a library of images that the artificial intelligence software kind of uses to fuse the images together. It's incredibly useful in making sure that you have a more accurate roadmap in order to plan complex procedures. One of the most difficult problems with it has been, though, that people have criticized it because the aorta obviously deforms when you introduce large devices. And so many of the companies introducing fusion imaging are now actually actively working on deformation protocols where you can change the shape of the aorta in real time to accommodate what you see on the screen. So it becomes an extraordinarily useful and accurate method of planning and road mapping your images. Next slide, please. What this has meant for us is that over the course of my time here at the Royal Free since 2014, we've actually seen quartiles of statistically significant decrease in radiation dose, and really we mean DAP when we measure that, most importantly in the operating room. And that has been with the introduction of a team protocol, the use first of a hardware-based imaging system, and then secondly, the use of a software or image-based fusion system to really decrease our radiation dose. But on top of that, the knock-on effects have been really brilliant. If I have the next slide, please. You can see that the introduction of fusion imaging and paying more attention to detail has also allowed us to decrease our contrast dose, which has been a huge impact on patient care. And then next slide, please. It also allows us to decrease our procedure time, which is a big impact on health economy. I think I have one slide left, please. So in summary, the fundamentals of radiation are really not that difficult. If I can get it, anybody can get it. And it's good to kind of remind yourself of them every once in a while. So please feel free to use this video. There's no there's no kickbacks I get from it. But really, I think the most important thing is showing up to a seminar like this today and paying attention to education and really getting your team actively involved in radiation dose and safety. Thank you for the time. Stephen, back to you.
Thank you, Tara. And I particularly like the image of the superhero there. Excellent. Thanks very much. So, yeah, a nice way to start off there. And I'm going to pass across to Eric Radtke from WIT. Now, Eric's organization is like ours. We have a bit of a mission to reduce radiation exposure to clinicians working in these sorts of operated environments. Eric is the Vice President of Worldwide Innovation and Technologies, Inc. They're based in Kansas in the US. Eric's got up especially early this morning to join us. Yes, the products that they supply have already been mentioned with Tara using the Radpad. So Eric, over to you, please.
Thank you, Stephen. Thank you, Dr. Mastracci. That was impressively more than an opening act and actually a tough act to follow. So next slide, please. So I want to talk today a little bit about why we need to protect ourselves and what doses look like in the field. I took this data from ORSIF, Occupational Radiation Safety and Interventional Fluoroscopy. This shows us a 6-fold increase in dose in the last 30 years. 40% of that related to cardiovascular imaging. That makes perfect sense. If we are familiar with the fluoro suite and the number of procedures that come out of the cardiovascular lab, there's probably a big link to CT imaging as well. But the takeaway is that doses are going up. Even while we're trying to reduce fluoro time, we see new technology advancing, new procedures. These new procedures take more time to execute. Patients are getting larger. We're just running against the curve in terms of reducing our radiation exposure, and that's how we get these kind of numbers. Next slide, please. I pulled together a lot of data. I'm going to try and just pull the hot points for you. We're looking here at a typical lab, team around the table. We're highlighting the dose to the operator's head, an average career for interventional cardiologists of 20 years. You can see an average dose to the head of 1,000 millisieverts. We don't have to get too upset yet. The skull will attenuate 60–70% of this, depending on which study you follow. So we'll take the high number and say, we're looking at maybe 300 millisieverts to the head over an interventional cardiologist's career. We'll keep that number in mind for a minute. The other interesting thing about this slide is operator number 3 in the bottom right corner of the slide. You can see their dose, their mean radiation dose. This is the lowest on the table. This is presumably the radiation technologist, and they've got the lowest doses of the table. Remember this when we come back through the slides. Next one, please. Next slide, please. We're going to be talking about a couple of conditions. These are not conditions specific only to the cath lab, but they do occur in the cath lab, and they all share chronic inflammation. Chronic inflammation is a result of radiation exposure to the body. So we want to highlight some of these things because they don't get the attention that often cancer and cataracts do. When we're talking about mental health, anxiety, depression, we can look at some of the hazard ratios. You can see in the middle column here, this HR is hazard ratio. We'll skip to the big one, cataracts. Everyone always talks about cataracts, and there's a hazard ratio of 6.7. So 6.7 times more likely to develop cataracts than non-exposed groups. There's other conditions on this chart that are significant like this. Orthopedic illness, we know about this, is lead aprons. It is the lead aprons doing the damage to the musculoskeletal system, but radiation weakens the body, thus exacerbating some of this process. So yes, it is the lead apron, but radiation is contributing to it. Also interesting here is anxiety and depression. Many professionals refer to it as burnout. The hazard ratio is almost as high as that of cataract, so it's something we should take seriously. I think a lot of people are a little bit apprehensive to talk about depression in the workplace, and many professionals are hesitant to talk about burnout. But as we'll see in some of the studies, radiation exposure to the brain can have a direct impact and role on mental health. So I think these are things that we should keep in mind when we're trying to protect our colleagues in the lab, not just from cancer and cataracts, but also protecting the brain, the vascular, and the immune system. Next slide, please. This is a conglomerate of about 5 studies that we like to refer to, and I use these to train physicians, nurses, and techs all over the world. The first one is talking about the immune system, some of the most highly radiosensitive cells in the body. This makes sense to us because the body's reacting to a threat. It needs to be very sensitive. They are the dosimeters of the body, and they tell us how the body's reacting because radiation is insidious. You can't see it, hear it, or smell it, so we only know when it's too late. The second study of here, X-ray techs were found to have 5 to 8 times more activated lymphocytes than control groups. So remember the previous slide, I said that the operator at the number 3 position, he had the lowest doses. These people, these stakeholders still had 5 to 8 times more activated lymphocytes. So their immune system was that much more active than control groups or non-exposed groups. And these guys have the lowest dose in the room. So think what's happening to the scrub nurse and then happening to the main operator. X-ray exposure caused immune system suppression via disturbing levels of critical cytokines IL-2 and 18. IL-2 and IL-18 are responsible for pro-inflammatory and anti-inflammatory responses in the body. Radiation exposure will negate these and reverse these. So it's really disrupting the body's ability to suppress inflammation when it needs to and to promote inflammation when it needs to. The next one, this is an interesting study out of the University of Nebraska. They didn't bring anything new to the table in terms of deterministic or stochastic effects of radiation exposure. What they found were the issues that are related to radiation exposure were occurring at doses much lower than recommended by the ICRP. So in the US, we have a maximum annual dose limit of 50 millisieverts per year. IRCP was finding this at about 14 millisieverts per year. So in Europe, you're looking at 20 millisieverts, and they were finding these issues popping up at around 14 or 15 millisieverts per year. So lower than the recommended levels by ICRP. That doesn't mean the ICRP is wrong or bad. It just means that we are getting more and more educated on the fact that no dose is a safe dose. DNA damage in the immune system occurs both in patients and operators. So Patients are radiated, then the operators are radiated. The operators are getting a fraction of that of the patient, but they're doing thousands of procedures over their lifetime in their career. So this is the buildup in the body. It's a cumulative dose of radiation that they get throughout their careers. And really what it does is it hampers the body's ability to repair itself. If we just gloss over the details, basically the radiation exposure is affecting the body's ability to repair and regenerate itself. So if we can look at the healthy cath lab study in the next coming slides, and we'll see how that impacts the body. Basically what we're talking about then, again, is chronic inflammation. So the reaction of the body to radiation or any intruder or toxin is inflammation. And that's what's happening in the cath lab for operators that are exposed to this chronic low dose radiation. Next slide, please. Early vascular aging, I think this is very interesting and rings very loudly with a lot of our physicians and consultants because they're often treating patients that have vascular conditions. Please go back. Radiation exposure is responsible for CIMT thickening. This is basically a thickening of the walls of the vessels. We know this happens with age. We also know that radiation exacerbates or accelerates this. So a lot of the conditions our vascular surgeons and cardiologists are treating, they're also experiencing as a result of their scatter radiation exposure. I think we'll talk about this in a little bit later, but also telomere shortening. This is just evidence that DNA damage is occurring. The telomere shortening happens with age as well, but with radiation exposure, this is accelerated. And again, this is the body's ability to repair itself. Next slide, please. When we talked about early on, the dose for interventional cardiologists to the head over their career might be 1,000 millisieverts. If you look at this dose ladder, you can see right there, 1,000 millisieverts, we're talking about cognitive deficit. We also said the skull will attenuate 60 to 70% of that, depending on the thickness of your skull. So we'll take the higher end at 70%. Still puts us in a dose range of 300 millisieverts over the career. And this is related to or linked to neuropsychiatric, neurophysiological, neuroimmune dose-related effects. Remember, our vascular system and our immune system is not just underneath our lead apron, it's also in our head and our extremities. So this exposure to radiation, even though it's the arms or the hands or the head, affects the entire body, the entire vascular system. Next slide, please. Continuing on with the brain, this is an interesting study. I refer to this slide as the mouse slide. So this is this study was conducted. Dr. Acharya was evaluating a solution for patients that have been treated for brain tumors. So radiotherapy for brain tumors. These patients were developing some cognitive, we'll just say dysfunction, slow memory test. And this is not the question we're discussing. They were studying the solution. This tells us they already know that radiation to the brain has an impact on our cognitive function. And this is something that has to be communicated with physicians and cath lab personnel all over the world, that they need to protect themselves, protect their brains. I think it's important because it wasn't long ago that the brain was considered not a radiosensitive organ. And what we're finding now is that radiation to the brain has a number of effects, impacts to the body. Again, we're talking about radiation exposure causing oxidative stress and inflammation. Inflammation has been linked. You can go to any hospital in any part of the world and find a pamphlet on inflammation. We're always treating inflammation. It's been linked to trigger depression, almost like an allergic reaction in the body. Next slide. More about low dose ionizing radiation depression. This is an interesting study from Loganowski again, talking about radiation being a factor in the genesis of depression. It can be either through the central nervous system or indirectly through organs breaking down in the body. This is just us painting the picture that we have oncology patients with radiation to the brain suffering cognitive deficit. We have disaster workers, radiation disaster workers suffering anxiety and depression as a result of radiation to the brain. And then we're going to bring it home here with the next slide, please. And we're going to talk about cath lab personnel. This is a neuropsychological testing of interventional cardiology staff after long-term exposure ionizing radiation. It's a relatively new study in terms of how studies go. But this is quite clear. It's showing exposed patients showed significantly lower scores in delayed recall, visual short-term memory, and semantic lexical accessibility than the non-exposed group. And the last one, this is an interesting one, the semantic lexical accessibility. This is our ability to recall that word. When we're speaking, we're talking, we say, it's a, you know, this is your semantic lexical accessibility. So this radiation exposure is having an impact on our cognitive function. I don't think there's any consultant, physician, nurse, or tech that wants to deal with that while they're in the lab. It's not a total sad story. We can protect ourselves, we can reduce this exposure, but we need to know why we're doing it so we can take protection seriously. Next slide, please. This is a graph from the Healthy Cath Lab study. I like this graph because it shows us over the career of a cath lab personnel. The light gray box is a control group, the non-exposed group. The blue, the pink, and the red are 5, 15, and greater than 15 years working in the lab. And you can see with all the conditions, skin lesions, the first 5 years, the exposure goes up, the body reacts. And that's normal. That's the body's job to do, is react to radiation exposure and repair itself. However, with this repeat exposure over time, the body's ability to recover it is going down. It's starting to break down. However, after 16 years, the body can no longer keep up and these conditions take over. You can see with orthopedic illness, if it was only the lead apron, then that line would be flat across 5, 15, and up. But this is showing us that the longer we're in the lab exposed to radiation while wearing this lead, it's increasing the breakdown of the body. Cataracts, we see this over time. Hypertension as well, same story where the body reacts at first, starts to repair itself, but then it just cannot handle the load. Hypercholesterolemia, this is like we talked about with the vascular aging. As the radiation exposure causes thickening to the vessel walls, it also causes gaps in the endothelium. This makes it difficult for the body to move plaque, and you have a stroke candidate. So anytime you have thickening of the vessel walls, you lose elasticity, and then you lose the ability to move plaque, then you have a stroke candidate. And I can say that all the consultants and physicians on the call will be able to relate to this. They see patients like this all the time. Typically, they're much older. With our physicians, what we're seeing is happening at a younger age because of radiation exposure. Next slide, please. So it's not all doom and gloom. Radiation is, we're not talking about fire and brimstone and death and danger, but we do need to be aware that there are things we should do to protect ourselves. It does appear through latest studies and that there really is no safe dose. There are limits allowed by governments, and this is always changing. If you study the history of allowable doses, you've seen they've dropped every year for the last 20 years. So we're going to get to a place where we know that zero exposure is the goal. We need to do what we can. We talked a little bit about ALARA, Dr. Mastracci, she said ALARA and time, distance, and shielding. So we'll just cover this quickly and then hand it over. Next slide, please. So ALARA, we've probably all heard this. We probably know it in our sleep as well as reasonably achievable. This is often talked about for the patient, but not often talked about for the operator. So what the patient gets, the operator gets. And over time, we need to be talking about how to protect the operator. How do we do it? Time, distance, and shielding. We want to limit our fluoro time. We've talked a little bit about this. We want to use different fluoro modes to reduce our dose. The distance, we want to increase our distance from the fluoro site, from the source of the scatter, this is the patient. And shielding, we need to protect ourselves. We know that we cannot reduce procedure times. We can improve them somewhat, but as we develop new technology, new techniques, we get new procedures, that fluoro time is going to continue. Distance, we can't step away. We can't step out of the room all the time. We find ourselves next to the patient. That's just the way it is. So it's harder and harder to distance ourselves from the source of radiation. So what do we need to do? We need to shield ourselves. Next slide, please. So time, distance, and shielding, we're talking about limiting fluoro time, frame rate, taking a step back during CINE and DSA acquisitions. Dr. Mastracci mentioned it briefly. CINE and DSA acquisitions are responsible for 60% of your dose in all procedures. So even if you have 2 CINE acquisitions and 20 minutes of fluoro, 60% of your dose is coming from the CINE acquisition. So we need to be aware that it's not just fluoro time, like Dr. Mastracci said. It is the acquisitions and the dose that is inside that fluoro time that is impacting operators and stakeholders in the lab. And then shielding. While we'd like to cover ourselves from head to toe, it's just not practical. We need dexterity, we need to be mobile, and we also need to breathe. So there are some things we can put in place to shield ourselves. Next slide, please. I won't spend long on PPE. We know about aprons and gloves, caps and glasses. Dr. Mastracci mentioned these as well. I just want to support these. These are ways we can shield ourselves and once the radiations come all the way to the operator. Next slide, please. Fixed hanging mobile shields. We have the hanging leg glass. I see these in every lab. I don't often see them used correctly. I often see them used decoratively off to the side or over somewhere else rather than down on top of the patient, creating a shade zone there. Table skirts, this is hit or miss. Sometimes if you're in the EP lab or OR setting, you won't see a table skirt or it'll be on the wrong side of the table. This is something we need to take note of because the majority of the dose is under the table. This is where the emitter is and this is where it's coming from, and we need to trap it down there. And then the mobile shields, the glass walls, you can always find these pressed up against the wall in a cath lab somewhere not being used. So whenever we're in a lab training with the team, I'm always pointing out, pull that thing over here, stand behind it, guys. It makes a difference. It matters. Next slide, please. And then, of course, the disposable shields that drapes we can put on the patient. Where these shields, they bridge the gap between the 25% of the operator's body exposed, their head and arms and legs are still exposed from the aprons. So we need to close that gap. We need to protect the head. We need a shield down on the patient to stop the scatter radiation coming off the patient and hitting the operators in the head. Approved shields are documented and tested and have been shown to reduce scatter radiation to up to 95% for medical personnel. Next slide, please. I think it's important that stakeholders in the hospital not feel apprehensive or nervous about asking for protection. Sometimes some people might see it as a sign of weakness or something like this. And I just want to encourage people that the FDA is even recommending that new regulations include the use of sterile disposable lead-free shields. So stakeholders in the hospital, don't be afraid to ask for them. Don't be afraid to protect yourself. It's also a recommendation by the FDA and the US government. Next slide, please. ICRP, also radiation protection. They've taken on and said drapes and pads applied on the patient can be effective in protecting the operator's hands for a number of procedures. They even have apertures that you can work catheters through. So here we are getting even closer to radiation protection workers talking about using protective shields on the patient to stop scatter radiation from hitting the operators. Next slide, please. And the last one, the SCAI multi-position paper. This is 5 bodies, cardiology bodies, that have endorsed best practice, saying that there's compelling data demonstrating reductions in exposure with accessory drapes. Disposable radiation shielding pads should not be refused due to their expense. So this is just telling us that even the bodies governing the cardiology, the interventional radiology, vascular societies have taken on that these shields can reduce operator doses to the head. We talked a little bit about why that's so important, and I just want people in on this call to know that they can ask for protection. They should be proud to ask for protection, and they're justified in asking for protection. Next slide, please. This last slide is just a reference for all of the studies. If you want to go back and read some of the papers that I've referenced and some of the studies that I've referenced, there for you to do so. I appreciate your time and hand it back to Stephen.
Okay, thank you, Eric. Lots of information in there, as I promised there would be. Want to move on very quickly to Professor Bijan Modarai. Bijan is the Professor of Vascular Surgery at Guy's and Tommy's. He's also Senior Clinical Research Fellow, at the British Heart Foundation. Has much research on aneurysm repair and great interest in the complex endovascular repair of the aorta. And I've also been reminded to say that at the bottom of your screens, to all the participants today, there is a Q&A session, and I think we're doing a good job at answering the questions as we go through. The panelists are responding during the course of the session. So the Q&A session that we planned at the end, we might eat into with the main content. So please keep your questions coming and also the answers coming as well during the course of the presentation. So Bijan, over to you, please.
Stephen, thank you very much, and thank you to you and your team for organizing this session. Next slide, please. These are my disclosures. Next slide. So we've already heard from the two excellent talks that have preceded this that chronic low-dose radiation exposure to healthcare workers may have some long-term health consequences. And this is in part a talk around the research that me and my team have done related to this, and in part a pragmatic description of how we can protect ourselves. Next slide, please. So I'm a vascular surgeon, and what we did a few years ago was put together 2 weeks worth of doses related to cardiovascular intervention in the hospital. So the top two are coronary interventions, then some peripheral vascular work, and then the lower 5 procedures are complex endovascular aortic repairs, an example of which you can see on the left. And these are longish procedures that require X-ray of the abdomen and pelvis. And you can see that these endovascular aortic procedures are associated with significant doses. And I think as vascular interventionists, we're currently being exposed to some of the highest doses out there. Next slide. What we've done more recently is used a technique called Monte Carlo simulation that uses the output from the hybrid X-ray device to calculate the doses that each of the organs of the operator receives. And this we did for just over 80 endovascular aneurysm repairs. And you can see that the calculated doses are highest for the brain, the lens of the eye, and the left breast. And that ties in with some of what you've heard already in the preceding talks. Next slide, please. But are these exposures actually of consequence? Well, they are. So I again want to reiterate what Tara said, is that radiation energy transfer to the DNA molecule causes DNA breaks. That's irrefutable. And what that does is that it induces a DNA repair pathway. And I want you to remember this one. It induces phosphorylation of this molecule H2AX to gamma H2AX. So gamma H2AX is a marker for DNA damage in your cell. And what happens is that the body then repairs the DNA damage, but it's not a free pass. In the process of repairing, there are some misrepairs, and that causes genomic instability, and eventually that causes cancer. So DNA damage and repair is not a free ticket. Next slide, please. So with this in mind, what we set out to do a few years ago was to find out whether there's any evidence that even the low radiation exposures that the operator may get during the course of procedures could cause any DNA damage. And to be honest, when I started on this, I didn't think for 1 second that we would find any evidence, because these energies are low after all, aren't they? So what we did was sample the peripheral blood of operators and isolate lymphocytes. Now, lymphocytes are exquisitely radiation sensitive. So if you're going to pick up radiation damage, you're going to pick it up in the lymphocytes. So we sampled operators that did open repair in green here on the graph, and operators that did endovascular X-ray guided aneurysm repair. And to my amazement, we found that when we analyzed the blood preoperatively, so you can see the pre-bars, compared with postoperatively, in the portion that used X-ray to guide the repair, so endovascular aneurysm repairs, there was an increase in the amount of gamma H2AX in their circulating lymphocytes. And there was no increase ever at all for any of the operators that did open repair. So this is irrefutable evidence that even with the low exposures, relatively low exposures that you get during the course of an endovascular aneurysm repair, the operator shows evidence of DNA damage in their lymphocytes. And again, corroborating this was that when we sampled that operator again the following day, there was absolutely no increase in gamma H2AX. So all the damage and repair have been done by then. Next slide, please. So, you know, we're not alone in getting exposed to radiation as part of our occupation. People during space flight also get exposure. And actually, it's interesting to see what NASA does when they're estimating radiation risk. All their algorithms are individualized. And notice that nothing about how the operator's risk is calculated in healthcare is individualized. It's all a broad threshold that we use for safety. So NASA uses individualized risk algorithms. It takes into account their age, their sex, other risk factors like smoking. And the limit is lower for females because when they studied victims of Hiroshima and Nagasaki, they found that the incidence of cancer in those exposed people, as they followed them along in the lifespan study, there were 3 times higher cancer risk in females compared to males. But in fact, you know, there is a paucity of biological data to inform specific risk for the individual. So again, what we wanted to answer as part of the study that you saw earlier on DNA damage was, well, is there any differential sensitivity between the operators? So next slide, please. So in the same operators where we'd found evidence of DNA damage, we took a sample of their blood and we irradiated it at fixed known doses in this irradiator that you can see on the left. And again, you can see that each operator mounts a different amount of DNA damage. So you see the operator in purple for the same dose as the others have received. He has got a huge amount of DNA damage. So again, some evidence that shows we may all have differential sensitivities. So applying the same safety threshold to all of us may not be the right thing to do. Next slide, please. So with this in mind, I guess we can say that the risk calculations don't account for individual sensitivity. And as Eric alluded to, the safest thing that we can have is to not be exposed to any radiation as part of our work stream at all. So taking the pragmatic view on things, you've heard about ways in which we can protect ourselves. Maximal personal protection should be key. In the next few slides, we'll again reiterate, and some of it has already been covered, but it will reiterate how important certain pieces of personal protection are. Next slide, please. So the lead garment is obvious. I don't think any of us would perform any of these procedures without lead protection. 0.35 millimeter lead or equivalent is safe for most procedures. You can have different configurations of lead garments, as you can see here with wraparound garments. The fit is really important. You saw the levels of exposure to the left side of the chest. If the fit around the arm is not good, then that produces a nidus for radiation to get into the left side of your chest unprotected. And the study suggests that your level of protection against this exposure should be more than 90%. But actually, you look at that box at the bottom, this is a study from Korea that shows the reality may be very different indeed. They studied operators for a 6-month period. They found that their exposure effective dose was approximately 4 millisieverts. And the actual amount of radiation that got through the lead was between 30 to 40%, depending on where they were studying. So be cognizant and be careful that just because you're wearing lead, it doesn't mean that you're fully protected. Next slide. Eric alluded to the musculoskeletal side of things. This is a study that showed that 75% of interventionists had back problems at some stage, compared to a quarter in the general population. And it does limit their ability to do the work. So to counter that, you may want to consider 2-piece garments and lead replacement. But the equivalence of that lead protection has to be checked. Next slide, please. And the other thing that's coming to the fore, as you'll see in the next slide that will be shown, is that exposure to lead as a consequence of wearing these garments is also a problem that we have to be cognizant of. So in this study, they detected surface lead in just over 60% of the garments that they analyzed. And they found that the determinants of the amount of lead that you found on these garments was the visual appearance of the shield. I mean, it goes without saying, if you've got an old, tired lead garment, it's going to shed lead. And also whether or not they use a hanger to store it. Next slide, please. This is our fellow, and I just took this picture to show how he could be better protecting himself, and trainees are particularly at risk because they haven't got their own personal protection items. He could have been wearing a lead hat that you can see here. Next slide, please. There is some evidence to show that, that using lead protection for the head can reduce the exposure. This is a study in anesthetists, and you can see that compared with above the cap measurements, the measurement underneath the cap is significantly reduced. Next slide, please. We've already talked about eyewear. Just to say, these are not a replacement for ceiling mounted lead shields. You have to use them in conjunction with reducing scatter from a lead shield. Next slide, please. And then finally, leg lead protection. Not many people are cognizant of this still, I don't think. Next slide, please. And I just want to show you the final bit of research that we did in our earlier study. You can see that the amount of exposure you get at the leg is significant. 145 microsieverts in these aneurysm repairs compared to the over and above exposure at the chest. Next slide, please. And to our amazement, when we studied these operators, so we're coming now full circle to the blood samples we took from the operators to check on DNA damage. You can see in red pre and post levels in operators that weren't wearing leg lead. But to our amazement, when we put leg lead on all the operators, there was absolutely no DNA damage response, showing how important it is to protect from scatter from below. So when these operators were wearing leg lead, it stopped the DNA damage on the lymphocytes that were being exposed in the lower leg, and then we saw absolutely no response at all. So make sure you wear leg lead for all your procedures. Next slide, please. And then just to finish up, to show you that personal protection is not universally well taken up. This is a survey around the world. We sent out monkey survey. I forget the name of it, but it was some sort of electronic survey, and you can see that not everybody's wearing lead caps or goggles, and I was disappointed to find that leg guards are only worn by just over 40% of operators. So I think seminars like this are very useful to propagate this evidence and make people protect themselves better. Final slide, please. So the take-home message, I think the biological evidence of even low dose exposure is irrefutable. And if you don't believe it, you're putting your head in the sand. So make sure as a trainee, as a consultant, you insist on maximal protection and show presentations like this to your trust to make sure that they are duty bound to protect you and provide you with any personal protection that is required. So thank you very much again to Stephen and the APC team, and I'm sure we look forward to some questions.
Excellent, Bijan. And I've been around this business for a long time, and I'm always learning. And I particularly like that marker that you pointed to there, the gamma H2AX, and how you've used that to make that link. So some compelling evidence in there. Thank you very much for that. Now we're going to have Alex is going to present a little bit on the regulations behind ionizing radiation, which is not necessarily just to do with radiation from X-rays, it's to do with all ionizing radiation. And he was also going to then facilitate a Q&A. But because of the miracle that is Zoom, we've been having Q&As as we've been going through. So we might not have a proper Q&A session at the end because the questions have been coming during the course of the presentations and hopefully been answered. So if you have got some questions, please pop them on the Q&A at the bottom, and hopefully we could get around to answering straight away, or not, we'll get back in touch at the end. So I'm going to hand over to Alex, who's going to take us up to pretty much the end of the hour. So thanks very much. Alex, over to you.
Thank you very much. Thank you for the introduction and asking me to do a brief presentation about the reminder on the ionizing radiation regulations. Next slide, please. So within our practice, we have laws and regulations relating to use of ionizing radiations. And these are mainly outlined within two main documents, which all the radiation users are familiar with. One is Ionizing Radiation Medical Exposure Regulations 2017, or better known as ERMA 17. There is a link to this if colleagues would like to look at and download the document. It's free of charge. The second one is the Ionizing Radiation Regulations, which is known as IRR 17. In addition to these, as a reminder, if any organization is also planning to use any radiation equipment, they also need to have a license from Health and Safety Executive, which the details can be found in this slide, and you should contact this link and you can register online and pay for it, and you will be entitled to use any form of X-ray. Next slide, please. In terms of governance, these regulations also come under some inspections by organizations and bodies set out by the government. So the ERMA regulations come under the inspection criteria by Care Quality.
Oh, have we lost Alex there? He's frozen. You still there, Alex? Trials of the broadband. Okay, so whilst Alex's broadband is reconnecting there, I noticed we did have a few questions down at the bottom. We're in the process now of just trying to figure out how we get all these questions together and we can respond to everybody maybe after the meeting. So let's have a look at some of the questions. Are all the panelists live at the moment? Are you able to?
Yes, Steve.
Yeah, excellent, excellent. We've got 4 open questions at the moment.
Hello.
Oh, you're back.
Sorry, I don't know what happened.
No, me neither. And I'm so sorry. I know those they're important.
I was on my last slide. Yeah. Do you want me to carry on?
David, is there any chance that we can get back to that last slide?
Yeah, we are back.
Okay, good.
We are back here. Yeah, this is my sorry about that. I don't know what happened. So it is also a legal requirement for each organization who uses ionizing radiation to appoint a qualified radiation protection advisor and also a medical physics expert. Also internally, you will have somebody who is known as a radiation protection supervisor who works within the organization and also helps and ensures compliance with the regulations. If you're not clear about this within NHS, you could speak to your radiation physics department or radiology department. And of course, within dental and private health sector, I think it's important to also mention that the regulations equally also apply to all the dental practices. There's some misunderstanding that sometimes these do not apply to them. And you can find various organizations who can help you with these services. And I think that brings me to end of my presentation. So I'll pass it on to you, Stephen.
Thank you, Alex. And in my Russian excitement towards the end of this, I forgot to introduce you properly and your full qualifications. Alex is a long-standing worker within the NHS, where he was the RPA up in Yorkshire for the Trust. And he's chartered clinical scientist and a certified radiation and laser protection advisor, as well as being an expert in medical physics. He was a PhD and assists with the registration of private cosmetic and medical clinics. So that's his credentials right there. So thanks, Alex.
Thank you.
Back to the Q&As as we come to wrap up. We've got one there at the top. The first one that's come from Sanjeev Bhatt. What is the average radiation dose for the operator during a routine angioplasty and a complex angioplasty? Which one of our panelists would like to handle that?
So, I mean, perhaps I can start. I mean, these are quite broad definitions. Perhaps the way to think about it is the amount of tissue that is being penetrated. So if you're performing angioplasty on the lower leg, then the doses tend to be lower because it's a smaller volume of tissue that you're trying to penetrate. Whereas as soon as you get into the abdomen and pelvis or the chest, then you need to penetrate a larger volume of tissue to produce the images. And so that's when the dose will increase. So it's all about awareness of where you're trying to perform the procedures, and also angulation of your C-arm. So as soon as you come away from AP, particularly in extreme angulations, depending on where the radiation source is, the dose to yourself will go up. So you just need to be aware where you are and how you're positioning everything when you're doing the procedure.
Thanks, Bijan. And it goes back to that awareness of being, you know, everything that's going on around you. There's not just the procedure, but the whole thing about this you can't smell, see, or touch going on as well that you've got to have in your mind. Thank you, Bijan. I've got a question. The next one down here probably is best for Eric about do the disposable shields increase the patient dose?
That's a great question. They in themselves do not. So they are non-lead, and they are they do not reflect radiation back to the patient. As with any radiation protection or any object, really, we want to keep it out of the fluorosite. Something like that you put in the fluorosite in the field of view will cause the automatic exposure controls in the C-arm to increase the dose. It will believe the patient is 200 kilos instead of 100 kilos. So the rad pad in itself will not increase dose to the patient. But if it's placed in the field of view, like anything else placed in the field of view, will increase the overall dose. So the short answer is no. The long answer is don't put anything in the field of view.
Okay. Thanks, Eric. And Alex, are there any questions from there that you'd like to either handle yourself, or you think the panelists would be in a good position to answer?
Yeah, there was one question that, let me just find it. So we heard about the 3 cardinal rules of radiation protection: time, distance, and shielding from ionizing radiation. Which one do you see as the most important for the operator?
Would that be one for Tara, maybe?
Yeah, probably Tara can.
I think it kind of defeats the purpose of having 3 principles if you have to pick the most important one. So I would sit on the fence and say they're all really important. I have personally increased my shielding after reading Bijan's research and kind of being more aware of my personal dose rates. And certainly we've done a lot of little tricks to try and increase our distance from the radiation source as well, including adding tubing if we're doing hand injections so that we can step back a couple feet. You know, so I would say I wouldn't pick one. I would say that you should really kind of pay attention to all 3.
Thank you. Very diplomatic answer there. Thank you, Sarah. And yeah, it's that blend, isn't it? It's trying to juggle those 3 balls equally. That's great. Well, I'm afraid that that hour has just flown by. We're now at 1 o'clock. We have still got some outstanding questions which we'll answer after this, hopefully directly to the wider group. But I really want to say thank you to all the speakers, the panelists. Thank you to you, the audience, for keeping with us during our very first webinar ever from APC Cardiovascular, never mind just for radiation protection. And I hope that everybody's got some good value from it. 1 or 2 protective tips and tricks that you can take back to your practice to make it safer for you to go to work, whatever that might be. So thanks very much for everybody's time. Thanks again to our sponsors, and watch this space, because I'm hoping there's some more discussions to be had in the future. Thanks again, everybody. Have a nice rest of your day.
Thank you very much.
Bye-bye.
Bye.